on the computer so everyone can see it as well.
Okay, hello everyone. So I'm just going to give a bit of a summary regarding the Case for Change document, which I'm aware that everybody who's joined today would have had a copy of. So a bit of context then behind the service itself. So back in October 2020, every clinical commissioning group received some guidance from NHS England to look to set up a post-COVID assessment clinic. Due to lots of hard work amongst providers, we were able to set that up in December of 2020. Now, in terms of the assessment clinic itself, it's not a self-referral service. It is referrals via your GP or via secondary care, so whether from hospital itself. Now, the assessment clinic itself at that time when it was set up was to obviously review a patient's needs and then to ensure that patient was supported and signposted into relevant services which we had in Derbyshire at that time. And I'm sure Anil later on in the session will be able to give a little bit more information about that. Now, moving further forward, we then received further guidance from NHS England, what spoke about let's try and develop these services further. And in April 2022, the service grew to include rehabilitation. So in terms of Derbyshire, there is two hubs. We have a hub in the north, which is based at Chesterfield Royal Hospital. And we have a hub in the south, which is based at Florence Nightingale Hospital, which was formerly London Road. And the type of rehab which is received there in general, there's lots of elements of rehab, and it's holistic care, is around breathlessness, vocational rehabilitation, fatigue, and health psychology, because a number of patients which come in for rehab have more than one symptom. And a great benefit we felt of rehab in this way was that people weren't going to be signposted to numerous different services. So that was just a bit of background in terms of the service which we currently have in Derbyshire. Now, why is this service being reviewed, which is one of the key reasons why we're here today.
Sorry, Scott, can I just pause you? Beth, the presentation's not on the screen. Thank you.
Okay, so back to drivers of why we're here today. So there is two key reasons to why the service is being reviewed. The first one is referrals. So when the service commenced, we've been averaging around 20 new referrals per week. And that's between January and February. And I think there was even a spike at one point when we had 60 referrals during a couple of weeks as well. So what's happened, though, is that towards the back end of 2022 and throughout 2023, those referrals have now dropped to around 12 referrals per week. So not far off a 50% drop in referrals over the past 12 months. Now, that is not just a trend within Derbyshire, that's also a trend we're starting to see across the Midlands and nationwide. The second key driver is to make people aware that the service is fully funded by NHS England centrally. So they provide Derbyshire Integrated Care Board with funding each year to deliver this service, and it's a rolling amount of funding that we receive. We've verbally been updated, so we've not had anything formal, nothing in writing or anything like that. We've verbally been updated that due to the continuous decrease in referrals, there is also likely going to be a reduction in funding to reflect this for 2024-25. So that's really the main two reasons why we're here today. Now, if, for example, there wasn't a funding concern or risk, we would also be reviewing the service as well, because I think it's fair to say that we have a duty to ensure that we deliver a service that provides value for money. And if any service we had saw a significant drop in referrals, we would also be going through this process. So there's more detail in the Case for Change, and I think there's a more in-depth case for change document as well, Beth, isn't there, which you can also access, which goes into far more detail about the data and some of that information. So that's just a bit of an overview of why we're here today. And before we go into the session itself, I wonder if there's any questions that anybody may have.
Yeah, if we have about 10 minutes of questions, if anybody does want to ask any questions. So if you did want to ask any questions, you can either type them in the chat box, or if you look at the top bar and there's a hand, you can raise your hand as well. So Mark.
Yes, there's one question in the chat box at the moment from Carol, and Carol says referrals dropping off, but we're still needing support. Are diagnoses coded by NHS? If so, why aren't our GPs contacting us directly about this service?
So I can probably answer a bit about how you access the service. That may be helpful. So first and foremost, all GPs are aware of this service and have received training and upskilling about long COVID symptoms and the condition. In terms of referral to the service, it's the responsibility of the patient, really. The patient would access that service by going along to their GP or through like secondary care, where obviously they'd talk through their symptoms. And the service receives patients who are suffering with long COVID symptoms 4 to 12 weeks after a suspected infection. So that is a bit of the referral process. Rather than actually a GP reaching out, it would be a referral which the GP would make into the service.
Okay, thank you, Scott. Margaret, you've got your hand up.
Yeah, I just wanted to know what steps you've taken to establish that the reason for the drop in referrals is not actually a drop in the number of people needing care. Because it's, physically speaking, given that COVID is still out there, is still causing long COVID, and it hasn't stopped causing people to have long COVID. Nothing about the virus itself has changed. Therefore, there are still people who are getting long COVID. So have you gone out into the community to explore why it is you're not getting referrals? Because you're not getting referrals because people don't need it. You're not getting them for some other barriers or other reasons. So what efforts have you made to go out and find out why?
I might bring in Anil from a more like medical perspective for some of this, but in terms of some of the questions out there. So first and foremost, in terms of like prevalence of long COVID, as you know now, we're no longer testing as a country for COVID symptoms. And from a national like perspective, there's no longer any data in terms of prevalence, so it's very, very difficult as commissioners to understand that need. So that would be a part question of that. In terms of reaching out to the wider public and community to try and raise the profile of this service, we have a health inequalities and research officer who's doing lots of work in pockets of Derbyshire, whether that's linked to deprivation, health inequalities, who's going out and has done a number of events as well. So we are trying to do an element of it to reach out pockets. And on a previous engagement session, it was explained by Fozia, who I forgot Fozia's surname, who was the clinical lead. I think the session is recorded from the previous session, who has also noted that there has been upskilling and training where we've seen low levels of referrals from specific GP practices as well.
Thanks.
And just from the engagement point of view as well, Margaret, so the staff at SAM has looked at who tends to get long COVID, so the population demographics, and then who's looking at the service, and then looking at if there's any inequalities in regards to that. And the area that they found that there was an inequality was areas of high deprivation. People weren't accessing the service. So what the Health Inequality Research Officer is doing towards the engagement report is putting a paper together to look at what are those reasons behind that, and start looking at some of those solutions to feed into the review as well.
And do you work with that? Sorry, I'm kind of obsessing here, but I was at my local service meeting yesterday. Do health inequality officers in different ICBs talk to each other about this kind of thing? Because it sounds like you're all doing similar things.
I'll come in there, Beth. Yes, he has touched base with other ICBs around us. So I think he's touched base with Nottingham, and we're waiting to have a conversation, do some work with them. So yes, we have started broadening it out a little bit to understand it wider.
Okay, thank you, Sam. Right, Carol.
Oh, let me just, yeah, can you hear me?
Yes.
Yeah. I was just going to highlight the fact that many people, I started on this journey, and I ended up going into a red zone because I wasn't well after a few weeks, and I was laughed at because I couldn't breathe properly when she was testing me. And when I faced the GP, there's a lot of disbelief, and also in your workplace as a frontline worker. So people who have been struggling for 3 years have disengaged from GPs because we all know we're ill, but the science hasn't caught up with us, and we don't, you know, it's a problem there. But I think you won't be getting a true picture of all the people that do need your help, because if the GPs reached out and got people who were coded and just said, are you aware there's a service here? I'm sure a lot of people would have taken up that invitation.
Yeah. Was there a question you wanted to ask there, Carol, or was it just obviously just?
No, I'm confused now, so I'm going to stop there.
No, that's absolutely fine. And Laura's put that she agrees with you as well in the chat as well. Where are we? Anthony, sorry.
Yeah, can I echo what Carol has just said? And have you done any work to validate the education of the GPs to actually check if they actually have learnt anything? Because I'm gamekeeper turned poacher here as a retired GP, and I understand well the difficulties that GPs have. We know a little bit about a lot of things. And I echo also what Carol says, that if a patient plucks up the courage finally to go and see a GP and they have a bad experience, they will not go back again. And I say that because after I retired for 5 to 10 years, I worked for an eating disorders charity. And this was a very prevalent experience among service users. The other thing I'd like to ask is, have you done any work to see how well GPs are coding for long COVID on their computers?
Okay, thank you, Anthony. I'm not sure who's best to bring in there. Is it Scott or Anvil? Do you want to come in both angles?
If I start us off with a couple of them, then Anil may be able to provide more of the detail about what the provider has actually been, the work they've been doing with GP practices. So from a commissioning perspective, when the assessment clinic and rehabilitation services were set up, there was VASCOMs, which took place in primary care, and there's information packs and documents which was received by all GP practices, including support with PCN. So that work certainly did take place. Now, in terms of the second part of that question, is that, did that work and was that embedded? That might be something Anil can pick up once I've just started speaking. The other point around the coding, about the quality of coding, it's not something I can answer here and now, but it's something I can probably take away as a question to speak to our data and analytics teams. But somebody who's had an insight working on the other side of the fence from a primary care perspective will probably understand some of those barriers and risks which come with those coding issues as well. But that's something we can take away for that part. So, Anil, could you say anything more regarding what you've been doing with primary care?
Thank you, Scott. Yes, yeah. Hello, everyone. I think one of the issues happened was we came across that GPs are finding these referral forms are too big and we don't have time to complete. So Sam, who is here, and myself and our medical lead, Fawzia Begum, we all met with the lead GP, and we have done that work, and we made this as simple as much. And they're also on chosen books, so they don't need to put lots of information which can be automatically captured, and they just need to put the reason for referral. So that is number one. And number two, we started sending communication letters to GP practices offering Quest sessions. There are already few booked, and I'm actually going one of them next week. So that is one. So we offer like lunchtime Quest sessions where we can come and just give a quick update. And third thing is, besides GPs, there are also these advanced practice nurses and advanced clinical practitioners or other specialist nurses. So through our DCHS ACP network, we approached them and they have asked for us an update. So we are again going to give an update to them on long COVID. Because it's not just, I think, GPs we should target. We have to target the whole healthcare professionals here, including pharmacists. The reason is sometimes patients not always go to GP. They might see a nurse or a specialist nurse or a pharmacist. So our aim is we want to target all the other groups as well, so that they can do initial screening. But we normally ask the referral to come from GP. Reason is they need to do a set of investigations and also make sure they rule out other alternative diagnosis before they send a referral to us. Say, for example, someone complaining of fatigue may have low folic acid or low vitamin B12, and so therefore we just want to make sure they have all the bloods and everything done before they send to us.
Okay, Anil, I'm just conscious of time, so if we just go to Colin, and then if there's any further questions, if you could put them in the chat box, and we'll either come back at the end of the session if we have time, or we'll reply by email if that's okay, because I want to get on with the actual workshop. Colin.
Yes, hi. Just a bit of a question. I'm a long COVID sufferer. I did see some specialist people at the Florence Nightingale Hospital at Derby, and they referred me, they said that they were so complex that they referred me to a group called, I think it's CASOP, C-A-S-O-P. I saw them, and after various tests they agreed I got a problem, but because I wasn't prepared to use 2 walking sticks instead of 1, they discharged me. I now feel quite out in the wilderness, and I just don't know what to do now. Can I go back to Florence Nightingale, or I don't want to start with the GP again because it all takes so long.
Go to Anil.
I would suggest, yes, Colin, please go back to the Florence Nightingale. There is a care coordinator there. Please contact them. If you don't have their contact details, I'm happy to put it in the chat box. If any problem medically, they'll come back to us. But I think, yes, I would say, please go back to them.
Okay, Neil, thank you very much. Thank you.
Thank you.
Thank you, everybody. Right, we are going to move on to the actual workshop now, but I just wanted to give you a little bit of an overview of the engagement that we're actually doing. So throughout this whole month, we're doing 5 different workshops across the city and the county. We're doing 2 virtual ones. This is the second virtual one that we've done. We've done one at the Harrison Hub yesterday, which is a support group in Derby City, and then Monday we are at Chesterfield at Ash Green doing a face-to-face workshop, and then on I think Wednesday we are at Florence Nightingale as well. So if anybody knows anybody else, if you'd like to come to those face-to-face events as well, please just log on and go onto our engagement platform to sign up to those ones as well. Other things that we're doing is we're doing a survey as well. So we're asking questions around people's service experiences, what's important to them about this service and that potential service as well going forward. So we've got a survey going live as well for over this month, and we're targeting the whole of Derby and Derbyshire as well. And we're asking people if it's around them that's used that service, is it their child that's used that service, or is it a friend or family, so if they're a carer or not as well. So everybody's welcome to complete that survey as well. It's got a few more questions on there than what we're asking today, because obviously we can't ask every question today, so we really wanted to get a bit more of discussion going on about these questions. So I'm going to start the presentation, and I'll double check that you can actually see my screen this time. Let me present. Right. Can everybody see my screen all right? The presentation?
Yeah.
Yeah. Okay, wonderful. Yeah. Do you think? So just a couple of house rules. So everybody, we listen with open mind, respect each other's views, and we'll stay muted if anybody else is talking. If you've not used Microsoft before, you'll see at the top of your screen, there's that channel across there. So there's just the different options. So you can click on the chat box and that will bring up the chat box. So everybody can have conversations in that. You can post questions in that, and you can post your answers as well to any of these questions if you don't want to do the Slido method as well. And then if you see the raised hand as well, so if you wanted to speak at any point, you can press on that and it will raise your hand as well. So how will this session work? So like I said before, there's a link to a QR code to Slido, and also Mark, if you could re-put the link in if you wanted to do it on your computer instead, that's fine, and it will come up with the questions that we're asking. But you'll also see everybody else's questions. Since this is the second one we've done, it's got everybody's answers from the previous session in there as well, so everybody's will come together. Or you can raise your hand and speak, or you can put a response in the chat box. So do whatever method is most comfortable for you. There's 3 areas that we're going to look at. So there's the current service experience, so the current service that you've used, and then the methods that you've accessed, and then talking about the future service as well. So within that case of a change document, the larger one, if anyone's read it, we asked all the different providers, groups across the city and county about what are current people's experience about the services. So on the yellow there, you can see people's positive experiences. So people spoke about there being really good communication, about the staff, about the treatment and care, and about the hubs as well, giving them better understanding of the condition. When it comes to negative comments or areas for improvement, we only got a few comments around that, and there was around travel and wanting a service closer to home. And then there was individual comments about a consultant having little understanding. There was a lack of psychological support, feeling that struggling and waiting times. So that's what we're trying to build on at the moment. So this is the Slido. So if you go on your camera part of your phone and take a picture of that, it would take you to a link and it will bring up all the questions straight away. That will be next to every single question as well. Or you can do the one that's in the chat box as well. So the first question is that we want to find out, thinking about the current service, what do you currently find works well with the service? So if you think of all the different aspects, from accessing the service in the first place to the referral, the waiting times, the communication that you had, the treatment and care that you had, and even being discharged as well. So all those different aspects that you can think about actually using the service.
Beth, just one from me. Should it be a blank box or should it already show?
Yeah, this is what everybody else said last time.
Right, that's fine. That's
yeah.
Just making sure. That's fine.
Yeah.
Thank you.
Just as a reminder, if anybody wants to put their answers into the chat, I will instantly put them onto Slido for you.
Well, Paul, you got your hand up.
Yeah, sorry, I'm struggling with the. I think I'm in a bit of a brain fog, so I'll just try and say what I would say. Once I started getting the treatment, that's very good. So I'm seeing the clinical psychologist who's helping to cope with the symptoms really, and not make them worse, and etc. So I'd say that's very good, and I didn't even think that would be worth doing, and it was very good for me. So I would say anybody who's offered that, even if they're cynical about it or skeptical, should take it, because it's made a big difference to me.
Yeah. Wonderful. Thank you, Paul. We'll get that option as well.
Okay.
Yeah, but a couple of you echoing what you're saying there as well. Treatment was very good as well. Yeah, good positive comments about staff as well and communication. We've got a couple of people who are typing, so let's let them finish. Generally some really good positive comments there. Yeah, and treatment and communication again. Okay, wonderful. Thank you, everybody, for that. We'll move on to the next question. So the next question is, what do you think could be improved with the service? So again, just thinking about all those different aspects, from initially being referred to how you access the service, to the waiting times, to the treatment and care, to the communication, and then to being discharged as well. All those different aspects that you might have an experience of. Paul, let's come in.
Yeah, if you're okay with me doing it
Absolutely,
this way,
it's fine.
easy for me. So I would say the waiting time was quite long. It would have been useful just to get some notification that you are still in the system and we haven't forgotten about you. Would take some of the concern about what you wait. The waiting is frustrating, so just knowing that something is happening would have been more helpful. Yeah. I mean, appreciate that there's a limited number of resources and they have to be shared out, so I appreciate that's why you have waiting.
Yeah.
I would say one of the issues I had was getting support for being able to or not being able to work, and originally that was offered as something that could help, but it didn't seem to, when I asked what could you do, it didn't seem to really marry in with what the company needed to be able to sign me off long-term sick, and it just seemed to stop. There wasn't any way that could progress, so I actually paid for someone to assess me privately to get over that hurdle. So that was sort of something that I was told would be there, but didn't seem to have an offering when it actually came to it.
Okay, no, thank you.
Okay.
Thinking we've got waiting times being mentioned quite a bit as well, getting support for not being able to work. Oh, okay, sorry, thank you. Thank you,
I'm going to put
Mark.
my hand down now, thank you.
All right, Mark wrote it in the chat for you as well.
Beth, I think somebody else has got the hand up, but I can't see who it is. Oh, it's just gone down.
Oh,
Dr.
Anthony.
Anthony.
Yeah, I understand that the service works well according to the brief it's been set, but I think one of the problems is that people with more complex needs aren't met, basically, and that's partly because the understanding about long COVID is increasing as we go along. But there's a desperate need either to have one consultant who has an overarching understanding of long COVID that could act as a resource to receive such patients, so that the patients don't need to spend a lot of time trying to find resources that might help with their more complex needs, i.e. it's an issue of signposting, I suppose.
Right, thank you, Anthony. We'll write that one up as well. Okay. Thank you very much. We'll move on to the next question. So thinking about being discharged from the service, either if you have been discharged or if you were to be discharged at some point in the future, what would be important to you? Anthony, is that a legacy hand, or did you want to come in again? Paul, did you want to give any feedback on this question?
I haven't been discharged. I think I'm coming to the end of my sessions. I think what would concern me is being discharged and having to go back on the waiting list and start again. That would be a concern, because it did take me best part of 6 months to get there. So I wouldn't want to have to go back to that start. So I think that's probably a discharge with a discharge with where to get back in, I think is probably would be important to me. And then if I'm discharged from one area, does that mean all the other ones are closed, or is there, if there's other help that's available, would I have to then go back to start again to access that?
Yeah.
Does that make sense?
Yeah, no, that's fine. Thank you.
Okay.
Yeah, I think having open referrals. Last person type, and then we'll move on to the next question. The next section is around access. So it's just asking everybody what type of access you use to use the service, whether that be phone, online, or face-to-face. Wonderful, thank you very much, everybody. So if you just click on the ones that you accessed or didn't, or you can click on more than one if you did. What methods did you tend to use, Paul, when you accessed? Were you face-to-face, on the phone, online, a bit of all of them?
I was on the phone. On the phone for the assessments, and then face-to-face.
Wonderful, thank you. Assuming Mark's putting that in for me. Anthony.
Yeah, I think it's of great concern that there's been a politically led strategy to suggest that COVID is over and not to use masks and social distancing and air conditioning. And I think anybody who's looked after somebody with long COVID will know that they are extremely fearful about reinfection. And yet, if they go to the hospitals, they find that, you know, people are not observing, you know, masking, and have seemed to have forgotten that that is an essential part in reducing the risk of infection. And this is another reason why patients with long COVID feel so isolated. So face-to-face is extremely important, but it's only good if the clients have faith in the people offering the service to continue to respect their fear of reinfection.
Yeah, and I think that kind of leads into the next question, to be fair. Anthony says, what would actually be your preference method of using the service? So are you happy with the face-to-face, the phone, the online, or do people prefer a mixture depending on what the situation is? So yeah, I think that kind of feeds into that part. Thank you.
You've got someone with a hand up who's just gone off, but I would say I find the phone difficult. I would prefer teams like this or face-to-face.
Yeah, okay, thank you, Paul. We'll record that. Okay, wonderful, thank you. I'll move on to the next question. I'm just a bit conscious of the time as well. So did you feel the travel time distance was reasonable to you face-to-face? So if you did go to those face-to-face appointments, did you feel that that travel time or distance was reasonable for you?
Can I say yes to that?
Yes, thank you, Paul. Okay, thank you very much, everybody. So thinking about the future service, what would be the key things that would be important to you for that service going forward? So just thinking about maybe what the good points of the current service are, what you feel that it would be good for that. Paul's on the phone. You want to give me anything verbal here, Paul?
Yeah, I appreciate you. Thank you. Yeah, I would say for me, it seems like we're still learning what's going on here. So I think future services, I think, need to encompass any research or new treatments that are prescribed, and especially like there's a lot of research comes in about protein groups and things that possibly don't are early stage at the moment, but it would be nice to think that if something comes along in the future, you're not forgotten about, and if it's appropriate, you'd be contacted, but I don't know how feasible that is.
And thank you for that, Paul. The next section, we're going to I'm going to ask Sam or Scott just to come back in and just talk about the opportunities for change. So some high level options have started to be looked at, looking at what could the possible future service look like. And we just wanted to talk people through these high level options and then get initial feedback off them. I'm just conscious of the time, so we might probably go a few minutes over, but really value everyone's input if you can. Stay for a couple of extra minutes. Okay, so these are the opportunities for change. So if Sam or Scott,
no, it's me, Beth.
Okay, Sam.
Right, as Beth said, they are high level opportunities for change that we've been exploring, and that there's 4 of them. So the first one is the post long COVID service is stopped in Derby and Derbyshire, and patients are signposted to the York Ovary Recovery website and existing services. So if the patient attended with existing symptoms that were similar to another illness, they would be referred into that service. Option 2 is to develop existing service to meet the needs of long COVID patients. This is where we would where we would think about looking at using the money, rather than offering a long COVID service, would be using the money that we get to bolster other services, other rehab services up. So we would give them money so they would look at their criteria, which would allow the patients to be referred in to another service. Option 3 is to allow the service to continue running as it is currently now, but with reduced staffing and funding. As Scott mentioned earlier, we know there's going to be reduced funding coming from NHS England because they fund this service, and reduce the staffing levels down. So we were looking at having a nominal service, doing that one. And option 4 would be to develop a service that provides support for the existing long COVID symptoms, mainly around breathlessness, fatigue and brain fog, which are the top 3 symptoms, and understand if any other symptoms could be included in the programme. So if other patients, because we know we're not testing, other patients presented at the GP surgery with similar symptoms, they could be referred into the programme and undergo the rehab programme to help them with the symptoms as well, although they may not have long COVID. Does anybody have any questions?
I shall move on to the next question as well, just while
Paul's just put his hand up.
Yeah, sorry, I realised I put my hand up physically rather than pressing the button.
I saw it.
The one thing I would say with that is what I found is it's the coordination that when you start referring across the different disciplines, the coordination seems to fall back to the GP who isn't a specialist, and I think that's there's a project management concept of that, just actually managing the logistics of feeding someone around lots of different services, and then there's a conflict of treatments or things that come back, which this isn't a criticism, but that falls on the patient to decide what you want to do based on all the different treatment options and suggestions that are coming back, and how to prioritize, etc. It's quite difficult if you start just trying to bring that into a general service without a coordinated approach and a project manager, for want of a better word, running that thing.
Thank you,
Thank
Paul.
you. Thanks.
Okay.
And just to let everybody know, we've just moved on to that question. So it's asking, what are your initial thoughts around those potential opportunities to change for the future service as well? So we'll feed that in as well, Paul.
This guy keeps coming up, Ginger Nat, that keeps coming up yellow. I don't
Oh,
know if
it's
he's
Anthony.
been seen.
Yeah. I mean, I worked for 30 years as a GP, and I have to say, I never came across a condition that is so physically, emotionally, socially isolating as long COVID, other than when I saw the first cases of chronic fatigue. And it's that sense of isolation particularly that I think suggests that the long COVID clinic should retain its individuality, because it takes a lot to get your head around what long COVID feels like from the point of view of the service user.
Thank you, Anthony. We've just got one question left after this one, so I appreciate, obviously, we're running a little bit over now, so thank you for staying with us. Colin.
I just want to say something positive about the service, and it's a personal, I'll be as quickly as I can. I had a telephone consultation with one of the COVID doctors, and from the symptoms that I gave her, she referred me to cardiology as an urgent patient. I saw Dr. Asif in Derby. He found that I'd got 2 very serious blockages in my arteries, and they had to perform a complex emergency procedure to correct this. So in one respect, I feel that it saved my life, even though I'm not too happy at the moment about how it's going, but because of that, I'm possibly still here. So thank you very much for that.
Thank you, Colin. Thank you for sharing with us there as well. We've just got one person type in, and thank you ever so much for everybody's input there. Oh, sorry, I think I just moved somebody on. If I move somebody on a bit faster, just if you put the comment in the chat box for me, we can link it in. So this space is just, is there anything else that we've not spoke about already that you think needs to be considered in the review, in shaping this new service? Anthony.
Yeah, I think the role of carers. I think carers tend to be overlooked a bit, and they need specific support. And again, I think long COVID is a fairly unique condition. Yes, you can go to Carers UK, but I think, yeah, long COVID carers need particular understanding. And the only other thing I would say is perhaps the underuse of people lived experience to inform the service. I know that you have 2 people involved in it, but for example, in the Quest sessions that were referred to, had they considered inviting, if not people with lived experience, because they would be worried about the risk of reinfection, but at least perhaps the advocates of the people who are suffering long COVID.
Yeah, thank you, Anthony. I think carers came up in another discussion that we were having in one of the other workshops, and there was a suggestion around putting something together for family members and friends and carers to actually teach people about what what's the difference, what's the symptoms, and all that, kind of giving them, so people have a better understanding as well when somebody has been diagnosed within their family. So thank you for that. I'm sorry, I can't see if anybody else got their hand up.
Yes, yes, there is. It's is it Carol?
Carol, sorry.
Yeah,
Sorry, Carol.
that's all right. I was just speaking from my own experience. I've pushed myself because as a single parent, I've had to push myself, and I'm the only breadwinner. So I'm just conscious that every anniversary or a period of time, I'm conscious that I'm actually getting worse year on year. And I think, and I know I've got microclots, there's no way to treat them. So I am mothballing myself till a treatment arrives. The impact on life and living is marked, and it is getting worse over time. I think being in the first cohort, I think I've got an idea of what this thing does. And for the past 8 months, I've had a frozen shoulder, so not the kind of thing that I would have had before COVID. So I'm conscious that it could potentially slowly disable me, and everything is getting slowly. I'm on a trajectory down, and that's quite frightening. So people who might not have needed this 3 years ago will definitely be needing it going forward. You know, until there are treatments, we're really stuck. So to take a service away as people are declining, it's such a shame, because the service won't come back, will it? That's the problem. Thank you.
Thank you, Karen. Thanks for sharing. Thanks for your input. It's just a couple of people still typing. If I start talking to everybody about what happens next, what's the next stage after this engagement work that we're doing? So we're finishing off for the rest of the month. The survey will be going live, and then the options will start being developed more. So they'll start looking at the viability of those different options, and then start looking at appraisal, and so marking things, so what's actually achievable, what's possible. So what we'll be doing after the engagement stuff is we'll be putting a report together of everybody's input, what everybody said, and that will feed into all of those developments and the appraisal process. So everybody's feedback will be fed into everything. And if you've not seen it already, it's the engagement platform, and the link's at the bottom of the presentation and on the paperwork that you've been sent out. And that will have a timeline at the top, and we'll be updating that. So we'll let everybody know when the engagement reports come out, and obviously, and then it'll start going on to the development process, where all of that engagement and what everybody said across the system will feed into those development options going forward as well. I shall end there. I'm sorry for running over there, everybody, and thank you ever so much for your extra time for staying with us. I can't change my screen either. Sorry, things all going all skew-whiffy. There we go, that's better. So I'm on 2 screens. Thanks for everybody for coming today. If anybody does have any questions that we've not got back to them about, Mark, if you could put the engagement team's email address in the chat box so people can get back to us, and we'll keep you up to date with what's going on in the engagement platform as well. So thank you very much and good evening.
Yeah, thank you, everybody. Thank you. Bye. Have a good evening. Bye.
Thank you. Bye-bye.
Thank you.